like to introduce our chairperson for the next session, Dr. Rakesh Kumar sir. He's MD Pediatrics and has done his fellowship in pediatric endocrinology and diabetes. He's working in PGIMER Chandigarh. He's the Joint Secretary at present, ISPE 2021. Also, he has been the Executive Editor, Journal of Pediatric Endocrinology, with special interests at childhood diabetes. And sir has many awards to his CAP, Commonwealth Academic Fellowship Award, RCPH Visiting Fellow Awards, ISPAT's Alan Rash Clinical Fellowship. And sir has published more than 80 publications and book chapters and more than 40 presentations. We warmly welcome you to the CME, sir. Handing over to you to introduce our next speaker.
Yeah, thank you, Dr. Monica, for that kind introduction. So, and at the same time, I would like to thank you and your team at the Rainbow Hospital, Bengaluru, for this wonderfully organized program. The academic feast, really, it looks good speakers from all over India, and very nicely charted out program as well. So to introduce the first speaker for today, Dr. Aspi Irani. I'm sure everyone who has some interest in pediatric diabetes would know him already. He really doesn't need much of introduction, but for the sake of it, I have to do it. So Dr. Aspi Irani is a consultant pediatrician at Nanavati Max Super Specialty Hospital, Mumbai. With his passion for children with type 1 diabetes, we know he's a co-founder and trustee for Juvenile Diabetes Foundation Maharashtra chapter. And we know that, and we have read these guidelines, ISPE guidelines for management of diabetes mellitus in children. And he has been associated for all editions of these. He has also contributed chapters on pediatric diabetes in many important textbooks, being followed by pediatricians in India. So now I hand over this stage to Dr. Aspi Irani, who would be having his talk on diabetic ketoacidosis in children. Dr. Aspi, sir.
Thank you very much, Dr. Rakesh, for the kind words. And thank you, Dr. Monica, and your team at Rainbow Hospital for inviting me as a faculty for the CME. Can I share the screen? Are the slides visible?
Yes, sir. Your screen is visible and it's, yeah, fine.
So my topic for today will be diabetic ketoacidosis. And this is something which every pediatrician will encounter once in a while in their practice. And every pediatrician must be familiar with the management of diabetic ketoacidosis. The pediatrician may not know the details of day-to-day management, but diabetic ketoacidosis presents as an emergency. No time should be lost, and the correct treatment should be started immediately. Now, when a patient with poorly controlled diabetes develops ketonemia, which progresses to acidosis, we call it DKA or diabetic ketoacidosis. DKA is always due to absolute or relative insulin deficiency coupled with increase in stress hormones. Please note, overeating never causes DKA. The insulin deficiency leads to decreased uptake and utilization of glucose. The increase in stress hormones leads to increased glycogenolysis and gluconeogenesis. And this A and B together lead to hyperglycemia, which has three major effects. One is osmotic diuresis. Two is hyperosmolarity. For every 18 milligram rise in blood sugar, the osmolarity goes up by 1. And 3 is glycosylation of hemoglobin. The osmotic diuresis leads to dehydration, loss of minerals, electrolytes, and depletion of RBC23-DPG. The hyperosmolarity leads to cellular dehydration with dilution of extracellular solutes and is the most important factor that correlates with the degree of impaired consciousness in DKA. And glycosylation of hemoglobin further reduces the oxygen carrying capacity of the blood. So the three factors which I've underlined, the dehydration, the 2,3 are DPG depletion, and the increased GHB, all lead to decreased tissue perfusion, tissue hypoxia, which may progress if untreated to impaired renal function and lactic acidosis. Coming to fat and protein metabolism, there is a switch from anabolism to catabolism. So there is proteolysis, release of amino acids, electrolytes and minerals, which are then drawn from the intra to the extracellular space because of hyperosmolarity. And there is lipolysis with release of glycerol and free fatty acids. The amino acids and the glycerol go for neoglucogenesis. The free fatty acids are re-esterified to triglycerides, which may be stored in the liver, leading to fatty liver, or released in the circulation with hyperlipidemia, but are largely oxidized to ketone bodies in the presence of elevated levels of stress hormones. The ketone bodies are excreted in urine, bound to equimolar amounts of sodium and potassium, further electrolyte loss. Being weak acids, they are neutralized by the bicarbonate buffer, and this leads to a compensatory hyperventilation, carbon dioxide washed out, and pulmonary water loss, further dehydration. And when the compensation fails, you have metabolic acidosis, which causes peripheral vasodilatation and negative inotropism, which together, along with the dehydration, add to the impaired circulation and very rarely to shock. Now, what are the causes of DKA? In a new case, it is because of a delay in diagnosis or delay in initiating treatment. In a non-diabetic, it could be either a failure to administer insulin because the patient can't afford it, because for some reason it's not available at that time, because the patient has decided to try alternative treatments like homeopathy, Ayurveda, or in adolescence, quite often with suicidal intent as an attention-seeking measure or as a manifestation of an eating disorder to lose weight. In a patient on the pump, it could be due to mechanical pump failure, which has gone undetected. And in a patient who has not been educated properly in sick day management, it could be because of an illness during which the appetite goes down and the patient unfortunately may decide to discontinue insulin, whereas actually the insulin requirement is even higher than normal because of the high levels of stress hormones. So knowing the causes, how do you prevent DKA? In a new case, by creating awareness of the early symptoms of diabetes. In a non-diabetic, by providing free insulins to the needy, by advising all the patients to always keep a reserve stock of insulin at home for any eventuality or during travel, by providing psychosocial support in all diabetes clinics, by regular screening for depression, quality of life, diabetes-related distress, and eating disorders. In a patient on the pump, the patient must be informed very clearly that whenever the sugar goes above 250 with ketones, immediately give subcutaneous insulin with a syringe and troubleshoot the pump thereafter. And all patients must be educated in sick day management to prevent DKA. So what's the importance of preventing DKA? Well, you may know that 90% or more of deaths due to type 1 diabetes in pediatric age group are due to DKA. And 2/3 of these are due to cerebral edema. There are a lot of recent studies which have shown that even in uncomplicated DKA, you have elevated levels of neuron-specific enolase and other markers of hypoxic ischemic encephalopathy. And therefore, even with a single episode of moderate or severe DKA, subtle alterations in cognitive functioning and cerebral microstructural changes on MRI have been described post even a single episode. And the risk increases substantially with repeated episodes. So it is very important to try and prevent DKA, as we discussed in the previous slide. It may not always be possible, and when it is not possible to prevent, at least see that it is picked up at an early stage. For this, anytime you have a patient who is either a non-diabetic or who comes with the classical triad of polyuria, polydipsia, polyphagia, the 3 Ps, with the 2 Ws, weight loss and weakness, despite increased appetite, If any patient has these features and then comes to you with severe abdominal pain and vomiting, with dehydration and yet having polyuria, with hyperventilation, a peculiar odor in the breath, and good air entry, not reduced air entry, and no foreign sounds in the lung, or with drowsiness, immediately consider the possibility of DKA, and you can diagnose it within a few minutes. Don't wait for laboratory tests by doing a bedside blood glucose and a blood, or if not available blood, then urine ketones. You can confirm the diagnosis from these symptoms on the basis of these tests and immediately begin the correct treatment without losing any time. Before we begin our discussion on the treatment, let me just run you through the lab tests. Of course, in real life, we will not wait for the lab tests to start the treatment. The lab tests have to be interpreted very carefully. A blood glucose below 200 does not rule out DKA. You can have this in a patient who's taken partial treatment with insulin and a lot of fluids without carbs, or who's been vomiting a lot with very little carb intake for a long period of time, or who has impaired neoglucogenesis. Recently, with off-label use of the sodium glucose transporter 2 inhibitor drugs to treat diabetes, we have seen a higher incidence of euglycemic DKA because these drugs work by increasing the glucose excretion in the urine, and at the same time, they do not have the anti-catabolic effect of insulin. Sometimes the blood sugar may appear low because of hyperlipidemia. We call this a pseudonormoglycemia. And in any child with euglycemic DKA, also rule out the possibility of methylmalonic acidemia, propionic acidemia, isovaleric acidemia. The urine ketones, as Dr. Tushar Godbole mentioned, are not very reliable. Why? Because the urine test measures acetoacetate, but the predominant ketone body in DKA is beta-hydroxybutyrate, which is not measured. So you have an initial underestimation. And then when you start treatment, the beta-hydroxybutyrate converts to acetoacetate. So you have an apparent persistence of ketones. So you may use urine ketones to diagnose DKA, but not to monitor. They may continue to remain positive for more than 24 hours after the ketosis resolves. And hence the blood test, as Dr. Tushar mentioned, using the point of control meter, which measures beta-hydroxybutyrate, is the best option. The hemoglobin, the BUN, will generally be raised, and these are markers of dehydration. Very important, most patients with DKA will have a high WBC count. It can be very high with polymorphs, but do not start an antibiotic unless band cells are more than 10%. The count remains high as DKA is corrected. There is fever, which is very unusual otherwise in DKA, or there is a focus of infection, because the raised count correlates with ketosis and is not necessarily a sign of infection. Similarly, amylase and lipase may be raised because of pancreatic ischemia in DKA, and do not suspect pancreatitis unless the abdominal pain persists after correction of acidosis, or the triglyceride is more than 1 or 1.5 grams. The serum potassium is always an overestimate. Even if it appears low, it is an overestimate. Remember, potassium is an intracellular ion which is released in DKA because of catabolism, and then is drawn to the extracellular fluid, and then is lost in the urine and to some extent in the vomiting. So the serum potassium actually reflects a balance between hypercatabolism and the glomerular filtration rate. And whatever it may be initially, when you start treatment, it will fall. It will fall as the GFR improves with improved circulation and as insulin drives the potassium intracellularly. So the ECG is a better indicator of potassium status. Look for flat inverted T waves, ST depression, prominent U waves, which are markers of hypokalemia, and which are perhaps the only indication for giving potassium in the first hour of treatment. Otherwise, we wouldn't. And look for hyperkalemia with tall peaked symmetrical P waves, which would be one of the indications for giving bicarbonate in the first hour. Otherwise, we do not give bicarbonate at all. The serum sodium will always be an underestimate, just as potassium is an overestimate. Why? Number one, dilutional. Number two, because of hyperlipidemia, which causes a pseudo-hyponatremia. It's important to know what the sodium is, what the true sodium is. True sodium meaning what it would have been had the blood sugar been normal. For this, you add 2 milligrams for every 100 milligram blood glucose above 100. To explain this further, suppose the blood sugar is 600, that means it's 5 hundreds above 100. So you multiply 2 by that 5 and add this figure, which is 10, to the lab sodium, which is, let us assume 134, the sodium level will be 144. When you start treatment, the measured sodium should slowly rise. As the blood glucose falls, it should rise approximately 5 millicoulombs per liter in the first 8 hours. Always calculate the anion gap. DKA is a high anion gap acidosis. Normally in DKA, it would be around 20 to 30. If it is above 35, there would be associated lactic acidosis, poor perfusion or sepsis. This is an important measure to monitor recovery from ketosis. And this will correct earlier than the bicarbonate corrects. The bicarbonate takes longer to correct because there's always some hyperchloremia. And of course, the urine ketone test would not be reliable. Also calculate the serum osmolality using this formula as I've shown here. It will be high in DKA. The aim is a slow decline in treatment. If you have a rapid decline, more than 3 milliosmoles per hour, or a decline to a level below 275, it is likely to be associated with intracranial complications. Now we have analyzed the lab reports. Now let us go on to the management of DKA as per the latest ISPAD and the NICE guidelines. So 3 things I will discuss here. What you do in the first hour. Assess the severity, what do you do and what you don't do. Assess the level of consciousness using the modified GCS. If it is below 14, there would be some degree of cerebral edema. If it is below 7, the patient will not survive or will survive in a vegetative state. The most important is to grade the severity of DKA using the venous pH and the bicarb, or if not available, only the bicarb. So we take bicarb below 15 as indicative of mild, below 10 moderate, below 5 severe, and we calculate the fluid deficit correction, 5%, 5 to 7% or 10% based on this parameter and not on the clinical assessment of dehydration. Why? Because the clinical signs of dehydration in DKA are not reliable. They are not reliable because of acidosis, wasting, which makes the patient appear more dehydrated than he is, and hyperosmolarity, which then preserves the intravenous volume, and so it makes the patient appear less dehydrated, and then it depends on the balance between the 2 factors. But there are 2 things you must document. Is the CRT more than 2 seconds? Make a note. Does the patient have weak peripheral pulses, hypotension, oliguria? All these are very unusual in DKA. If that is there, then the patient has shock. Now, make a note of this because the fluids you give in the first hour will depend on this observation. In the first hour, we give normal saline. This is after you have addressed the A and the B of resuscitation. No colloids. Routinely, we give 10 cc's per kg over 1 hour. If there is poor tissue perfusion, we give 10 cc's per kg over 15 to 30 minutes, reassess at the end of it, and repeat if needed. If there are evidences of shock, we give 20 cc's per kg as rapidly as possible, and then reassess and give repeat boluses, now at half the rate, till the circulation improves, and we consider the use of iron drops. It is also important to remember what you should not do in the first hour. Never ever give insulin. No exceptions. Do not give potassium unless, as I discussed, the serum potassium is less than 2.5 or there are ECG changes, in which case potassium may be given in the first hour at the rate of 20 millicoulombs per liter of IV fluid administered. And never give bicarbonate, with only 2 exceptions: life-threatening hyperkalemia or pH below 6.9 with circulatory failure. And in that case, and only in that case, give it at the rate of 1 to 2 milligrams per kg over 1 or 2 hours as a slow infusion. Now coming to the period beyond 1 hour. The first hour is very crucial. In the second hour and beyond that, there are 3 things to discuss. How much of fluid do you give, at what rate, and which type of fluid? How much potassium do you give? When do you start the potassium? And how do you give insulin? Coming to the fluid, what rate? You give a sum of maintenance and deficit. You calculate the maintenance using the Holliday-Segar formula, which every pediatrician is familiar with. The maximum weight for this calculation recommended is 75 kilos. And you calculate the deficit, as I showed you in the severity of DKA slide, as 5%, 7%, or 10%. But you subtract the bolus given in the first hour or earlier if the patient received some treatment before coming to you. But do not subtract boluses if they were given for shock. At what rate do you give? You give the deficit evenly over 36 to 48 hours. In obese patient, use the ideal body weight for height, not the actual weight. And for weights above 32 kilos, keep twice the maintenance rate as your C. Ongoing losses, do not add. If there are urinary losses, if there are excess gastric losses, gastric aspirate, then you can replace it as half normal saline with KCl. Which fluid do you use? Beyond the first hour, it depends on whether the blood sugar is above 250, below 250, or below 150. If it's above 250, normal saline or half normal saline. If it's below 250, half normal saline with D5 added to it, and you may add D5 earlier if the blood sugar was dropping faster than 90 milligram per hour. But when do you decide in the first 4 to 6 hours whether to use normal saline or half-strength saline? Do you continue normal saline longer beyond 4 to 6 hours? That would depend on the monitored sodium and osmolarity. Is the sodium rising appropriately? Is the osmolarity decreasing appropriately? Then it's fine. When the blood sugar goes below 150, you switch from D5 to D10. Consider lowering the insulin dose because you want to continue the insulin not till the blood sugar is normal, but till the ketosis is corrected, which takes much longer than correction of the blood sugar. Now, this was a landmark study published in NEJM in 2018. A large number of children below 18 years with DKA was studied, and there were 4 different protocols using normal saline, half normal saline, slow hydration over 48 hours, or rapid rehydration, where 50% of deficit was given in the first 12 hours and 50% in the next 24 hours. And what did they find? They found no difference in the outcome. Of course, they used only those cases with GCS above 11. No difference in the outcome short-term, that is cerebral edema, or long-term, that is neurocognitive deficits. So the moral is, do not unnecessarily restrict fluids as per the earlier guidelines if clinical signs suggest need for circulatory volume expansion. A little bit about normal saline, isotonic saline. How normal is it? How isotonic is it? If you look at the chloride content of normal saline and compare with plasma, it's so high. And even the sodium is slightly high. In fact, Ringer's lactate, Plasma Light, and Hartmann solution have a more appropriate chloride and perhaps a more appropriate sodium content. So should we be using these solutions? Unfortunately, there are not enough studies in the pediatric age group, but the few studies which have compared normal saline with Hartmann's or Plasma Light have not found any difference in time to resolution of DKA, in length of hospital stay, or in mortality. And one study which compared the incidence of new or progressive acute kidney injury also found that there was no difference in the time to resolution of acute kidney injury between the two groups, although theoretically the use of these solutions is very appealing and we await more studies. Coming to potassium, you add potassium to all the fluids after the first hour, provided the serum potassium is less than 5.5 and patient is passing urine at the rate of 40 milliculins per liter. If there is hypokalemia during treatment, suspend insulin till it is corrected. If it is very severe, and if you need to give more potassium than 40 milligrams per liter, then and only then consider a central line and cardiac monitoring. Coming now to insulin. If the patient is on the pump, stop the pump. Insulin ideally is given as an IV infusion. Start after minimum 1 to 2 hours of IV fluids. Starting it earlier can cause severe hypokalemia, can cause cerebral edema, and can lead to shock by driving fluid intracellularly. Use only short-acting human insulins. Do not use analogs because analogs have no advantage over human insulins. when given IV. No bolus is to be given because a steady state is reached with an IV infusion within a few minutes. The IV tubing should be flushed with insulin solution initially to saturate insulin binding sites, and the IV solution should be replaced every 24 hours to prevent inactivation of insulin. The routine dose recommended was, and to some extent is, 0.1 unit per kg per hour, but now many studies have shown that half the dose is equally effective and may be safer, at least in mild cases, in children below 5 years who are more sensitive to insulin, if there is a low potassium or after the blood glucose goes below 250, provided the beta hydroxybutyrate is falling and blood sugar is dropping at more than 50 mg/% per hour. If insulin is not possible to be given as an IV infusion, or if there is no facility for admitting the patient in the intensive care, as happens very commonly during the COVID season, then the ISPAD has come out with guidelines. You can use subcutaneous route with Lispro aspart or with regular insulin. The dose would be with Lispro aspart 0.1 unit per kg per dose 2 hourly, and with regular insulin 0.15 unit per kg per dose 4 hourly. If the response is not good, you can reduce the interval between the doses, or you can increase the doses based on the blood sugar before each dose. If the circulation is poor initially, subcutaneous insulin may not get absorbed, you can give the initial doses intramuscularly as regular insulin. And this would only be for patients above 2 years with pH above 7.1 with a normal CRT and after 1 to 2 hours of IV fluids. It is recommended by many that basal insulin should be continued during DKA treatment, at least in a known case of diabetes. Give the usual dose at the usual time. And how does it help? Some insulin always remains on board. So it prevents a rebound hyperglycemia if you have to stop the IV insulin, say for hypokalemia, or if it gets stopped for some other reason. And it will speed the transition, as Dr. Tushar also mentioned, from IV infusion to subcutaneous insulin. The insulin infusion, as I said earlier, has to be continued till acidosis is corrected. Till then, try and keep the blood sugar between 100 and 200. If it goes below 100, you will stimulate the counter-regulatory hormone response, which is not desirable. If it goes above 180 or 200, you may have osmotic diuresis, again not desirable. And if there is impending hypo, then you can reduce the insulin infusion, do not stop it. You can increase the IV dextrose concentration, and if at all required, you may give 2 cc's per kg bolus of D10. My last 3 slides. Coming to cerebral edema, which I mentioned earlier, is the commonest cause of mortality in DKA, suspected in a patient who develops severe new onset or progressive headache or has recurrence of vomiting during treatment, in any patient who becomes suddenly restless, irritable, agitated, confused, more drowsy, incontinent, or the Cushing's triad, inappropriate bradycardia, rising BP, or abnormal breathing pattern, or if you have specific neurological signs, which of course would mean it's a little late. When you suspect cerebral edema, do not wait to prove it with any investigation. Start immediate treatment. The initial treatment recommended is 20% mannitol, 0.5 to 1 gram per kg over 10 to 15 minutes. If there's no response, in 30 to 120 minutes, you can repeat it, or you can give hypertonic saline, 3%, 2.5 to 5 cc's per kg over 10 to 15 minutes. Elevate the head end of the bed, reduce the fluid rate by 1/3, but make sure the BP is maintained. And if you have to intubate the patient, avoid hyperventilation, because PCO2 going below 26 can also aggravate cerebral edema. And after the patient is stabilized, then go for a CT scan to rule out other possibilities like intracranial venous thrombosis, hemorrhage, or a mucormycosis. When do you say ketosis has resolved? When the patient is alert, ready to eat, can tolerate oral liquids or food, the venous pH is above 7.3, bicarb is above 15, anion gap is below 12, and most important, the beta hydroxybutyrate is less than 1. Stop the IV infusion more than 30 minutes after giving subcutaneous insulin, or if the patient is on pump, at least 60 minutes after having started the pump. And finally, do not send the patient home without addressing the cause of DKA and making sure it does not recur. And thank you for the patient hearing.
Thank you very much, Dr. Aspi. There are not very many questions in the chat box. Can I have a small question, sir, for the audience?
Sure.
So what are the practical reasons where we need to think that diabetic ketoacidosis in a particular child could lead on to cerebral edema? In a sense, that what are the prognostic factors at admission, maybe at the start of treatment, where we could predict cerebral edema and avoid it, prevent it? That's one. Yeah. Yes, sir. Please.
So the factors which correlate with cerebral edema are a new patient with diabetes, a younger child, a longer duration of diabetes, the lower the pH, the lower the bicarbonate, the higher the risk, and the lower the PCO2, especially the PCO2, and the higher the BUN, the greater the risk of cerebral edema. Earlier, it was believed that cerebral edema occurs because of osmotic shifts during treatment. But today we know that quite a few cases of cerebral edema may occur even prior to initiation of treatment. So the severity of the process, the duration of the process, the age of the patient are very important factors. And the biochemical factors which are important are not so much the osmolarity or the blood sugar, but the pH, the PCO2, and the BUN.
Okay, thank you. Thank you, sir. So there is a question now in the chat box about a patient with cerebral edema suspected and has fluid-resistant shock and hypotension. Can we give mannitol?
If the patient is in shock, then giving mannitol may not be the best option. The reason being that mannitol can cause a diuresis. Mannitol can also cause a little lowering of the blood pressure. In such a case, probably hypertonic saline would be the better option. But this, I mean, the patient in shock, I don't know if you're referring to a patient who comes to you initially at the very presentation. At that time, what would be important is your fluid boluses and probably addition of inotropes.
So practically shock will take precedence over everything else. So that's the basic rule we have to follow.
Absolutely, yes.
Another comment or maybe question by Dr. Leena, one of the panelists. So role of basal insulin while managing DKA. So at what stage maybe we should start basal insulin? Yeah.
So what we would do is, if a patient is a known diabetic who's already on treatment and comes in DKA, we would continue the basal insulin that the patient takes, right, at the normal time. And if it's a new patient, then when we anticipate that we may be taking the patient off IV insulin, now even if the DKA is corrected, we take them off IV insulin only when it is the next meal time. But we would probably start the basal insulin when we know that the patient is now recovering from DKA, and very soon we will be taking the patient off IV infusion. So that when we take him off the IV infusion, there is already some basal insulin in the circulation.
Thank you. Thank you, sir. So we move